Hi, I'm Dr. Jennifer V. Brown, your stroke specialist, and today we're going to discuss ankle self-mobilizations to improve motor recovery after stroke. So after stroke, foot drop is common. The foot is in a downward position because the muscles aren't strong enough to pull it up. And in this position, the ankle will get stiff. However, ankle mobility is needed so that the muscles can contract asymmetrically, concentrically, and eccentrically for all the movements needed for functional activities, including sit to stand, transfers, walking, negotiating stairs. A physical therapist may not always be present to mobilize the ankle. Therefore, learning how to do self ankle mobilizations is very important. So, I use a door stopper. I teach individuals with stroke to put the narrow end of the door stopper under the outside of the heel in the back. This will help the heel get flat because usually the ankle is turned outward, and it will allow the tibia or the leg bone to move forward, backwards, side to side, and rotate on the ankle joint. Last, it helps to activate the muscles needed to move the leg and foot in all the positions needed during functional activities. So let's look at some of the videos. And before we get started, I want you to know that I start off with a chair with a solid seat that's usually the height of the leg. It will make for efficient and effective standing. Once you get stronger and moving is easier in the chair, then you can go to a lower surface and a dynamic surface like a couch or a bed. Always have the clients practice with the shoes on, and thereafter they can practice with a non-skid sock on, but on a non-skid surface. Remember, the first activity is to weight shift forwards, backwards, side to side, and at a diagonal if you need to practice reaching in sit. All of these movements increase the load on the foot and leg. But more importantly, I need you all to practice scooting. That's when you lift the body, generating a lot of force through the legs, and load the feet, the ankle, and the legs, which is needed for strengthening, improving the range of motion at the ankle joint. Let's watch this video. So notice in this video, I remove the strap, and that allows for more leg movement forwards, backwards, side to side, and rotation if needed. And in this video, there are no shoes on. So what are the clinical questions to ask? Is there mobility in the low back, hips, knees, and ankles needed for these movements in which you are really loading the leg by lifting your buttock off of the surface? Is there enough strength in the trunk in the lower extremity to do the weight shift forward, backward, side to side, as well as the scooting movements forward and backward, side to side? And what is the clinical significance of all of this? Self-ankle mobilization with movement, MWM, has shown to improve functional activities, particularly walking. And before we can walk, we have to transition to stand. So these movements are perfect to get to that higher level of function. Remember, I'm your trusted source in all things stroke neurorehabilitation, particularly as it comes to ankle foot orthoses, walking for analysis and treatment. And don't forget your references. Evidence-based practice. You have to know it, to use it, and apply it appropriately to neurorehabilitation. Thank you for watching this video.